Okay, so let's move now to the sclera. The outer is rough and brown in color. And this brown in color is, or this brown color is due to the melanocytes of the choroid. So you may wonder that the sclera is whitish in color from outside. So do you think that it will be the same color inside? The answer is no. It will be brown in color from inside. The outer surface of the sclera is covered by the tenon capsule and the conjunctiva and attached by loose connective tissue called the episclera, as we will see now, while the inner surface is lined by the endothelium, which is separating the sclera from the supraciliary space and the suprachoroidal space. The outer surface receives the insertion of the extraocular muscles, so the extraocular muscles are attached or insert into the sclera. So if we have a section into the eye, so we have, this is the cornea, and this is the sclera. The sclera is covered from anterior to posterior by the conjunctiva, by the tenon capsule, which splits into the anterior tenon capsule. The tenon capsule is one of the fascial covering of the eye. So the tenon capsule is divided into the anterior tenon and posterior tenon. The anterior tenon is just beneath the conjunctiva, while this is the conjunctiva and tenon are then overlie a vascular layer, the superficial layer of the sclera. It's a vascular layer of loose connective tissue called the episclera. And while the episclera is resting on the sclera. While posteriorly, it is connected by collagen fibers to the tenon capsule. The thickness of the sclera is one of the major topics that is asked in the exam because it has a clinical importance as well. So the sclera is thickest posteriorly at the around the optic nerve. So this is the thickest part of the sclera, making about 1 millimeter, while the thinnest location of the sclera will be at the insertion of recti. So at the insertion of recti, will be the thinnest part of the sclera, making about 0.3 millimeters. So does this has any clinical importance or surgical importance? The answer is yes, because this thinning of the sclera will make it liable to perforation in case of strabismus surgery. So we remove the extra, we suture the extraocular muscle in strabismus surgery, so we may cause inadvertent perforation of the sclera. And in retinal detachment surgeries, using the conventional retinal detachment surgery using the buckle, again we may cause we hang the extraocular muscles by sutures, so we may cause perforation of the sclera. So this will require careful placement of sutures. One of the questions that has been asked before in the MCQs of the ICO is the commonest location of scleral rupture after trauma. So if a patient received a blunt trauma, what will be the commonest location for trauma? This will be if, for example, if we have a trauma, so the most common site of perforation of the sclera will be opposite the site of impact in like of a circumferential arc. So if the site of trauma, like from here, this is the arc will be the site of perforation. The second most important location for perforation will be around at the insertions of recti. So this will be 5.5, 6.5, 6.6, 6.9, and 7.7 millimeters, which are the insertion, the distance of the insertion of recti from the limbus. So these will be again the common locations for perforation due to thinning of the sclera at this location. Also, one of the common locations for perforation will be, or rupture of the sclera will be the equator of the globe. And finally, the most common site is the superior nasal quadrant at the limbus. So superior nasal quadrant near the limbus is the commonest site for superior nasal for scleral rupture, and this information are from the American Academy. So what is the color of the sclera? So we all know that the sclera is usually white in color, but sometimes it can be brown due to heavy pigmentation, especially in dark races, or yellowish in color, especially in people who have jaundice. But sometimes some people or some patients may have a blue sclera, and this blue sclera occurs due to scleral thinning, as what it occurs in myopia due to stretch of the eye, or infants due to poor collagen formation or underdevelopment of collagen fibers of the sclera, or ophthalmos due to enlargement of ophthalmos, meaning that there is congenital glaucoma, so this leads to increasing the size of the eye, and over staphyloma. So staphyloma meaning that there is bulge of the outer coat lined by the middle coat, and this bulge will be bluish in color. Let's come to one of the main topics that's asked in the exam, which is the perforations of back of sclera. So the perforation of the back of sclera, it is one of the very hot topics that are asked in the anatomy. You should know them clearly. You should have a clear idea about what are the structures that perforate the sclera from behind. So in the middle, we have the optic nerve, and we have the two long posterior ciliary arteries and joined by two posterior long ciliary nerves. We have short ciliary arteries and the short ciliary nerves, and finally the vortex veins. So here is a section at the back of the globe. So what are the perforations? We have first the optic nerve, and in the optic nerve, within the substance of the optic nerve, there is a major artery and a major vein. They are called the central retinal artery and central retinal vein. Around the circumference of the optic nerve, we have two long ciliary arteries, or two long posterior ciliary arteries, joined with two long ciliary nerves. So you remember when we were talking about the two long ciliary nerves that supply the cornea? Here they perforate the eye at the 3 o'clock and at 9 o'clock. Then we have numerous about 10 to 15 or about 15 to 20 short ciliary arteries and short ciliary nerves that are arranged around the circumference of the optic nerve. And finally, we have 4 vortex veins, which are responsible for drainage of the venous supply or venous drainage from the eye, and they are located 4 millimeters behind the equator. This is again important and asked frequently in the MCQs. So the vortex veins are the veins that drain the blood from the eye, and they are located 4 millimeters behind the equator. So just some important anatomical landmarks here. We have, this is the fundus picture. So we have, this is the optic disc, and this is the posterior pole. So this is the posterior pole occupied by the fovea. So we have a relation between the optic nerve and the fovea. The optic nerve is above and nasal or medial to the posterior pole. So it is about 3 millimeters medial and 1 millimeter above the posterior pole. So what is the optic nerve? The optic nerve here, like here, is you have this is the sclera, and the sclera is not continuous at the site of the optic nerve attachment to the eye, meaning that there is an area in which it is perforated by the fibers of the optic nerve. This area is called lamina cribrosa. So lamina cribrosa, it's a part of a sclera which is present at the site of the optic nerve, which is carry the fibers of the optic nerve. As you can see here, it can be clearly evident in some patients by presence of perforation. So these are perforations or fenestrations are due to passage of the optic nerve fibers. So this makes the lamina cribrosa a vulnerable site for rise of the intraocular pressure, meaning that if in case of increase of the intraocular pressure, all of the fibrous wall of the eye will be tough, except for the lamina cribrosa. This will lead to this pressure will be pushing more or causing more damage at the area of lamina cribrosa, which carry the fibers of the optic nerve. This will lead to loss of the optic nerve fibers, leading to glaucoma or glaucomatous cupping. So How does this lamina cribrosa appears in ophthalmoscopy or appear on the electron microscopy? So here is the section of the lamina cribrosa. You can find that it resembles like a net. So there is a net with many pores. It's about 200 to 400 pores, and these 200 or 400 pores are arranged in a specific configuration, meaning that the largest pores are superior and inferior. So they are arranged in an hourglass pattern, and this hourglass pattern will make these pores have the thinnest connective tissue wall, meaning that if we have a lamina cribrosa with a pore that it is small, this means that the connective tissue wall will be large or thick. However, if we have a large pore, then this will mean that the connective tissue wall will be thin. And this thin of the optic of the wall of connective tissue at the lamina cribrosa will make these areas, superior and inferior, most vulnerable to glucomatous damage. And this is the basis of what is called isn't rule. So this is a section of the optic nerve. This is the inferior rim, the superior rim, the nasal rim, the temporal rim. So those who practice ophthalmology will know that in glaucoma, the vertical cupping is much more important than the horizontal cupping, because the vertical cupping occurs earlier than the horizontal cupping in case of glaucoma. And why the cupping occurs earlier? This is because the vertical and the horizontal and the superior and the inferior neuroretinal rim are more vulnerable to damage by rise of the intraocular pressure, and this will be dependent on anatomical facts which we have just mentioned. So if we did an OCT scan of these patients, you will find that the upper quadrant and lower quadrant are most affected, and this goes with the glaucomatous damage. Let's now talk about the microscopic picture of the sclera. So we have from superficial to or from anterior to posterior, we have a layer, a vascular layer called the episclera. So this is the most vascular layer of the sclera. So you see that the sclera is whitish. Why? Because it is usually lack of blood vessels, or its vascular supply is minimal, while the most vascular supply is present in the episclera. So the episclera is more vascular anterior than posterior, and the scleral stroma formed by bundles of the collagen fibrils. So these bundles of the collagen fibrils are parallel to the limbus, and at the region of insertion of the extraocular muscle, they become meridional. So they just interdigitate with the insertions of the extraocular muscle, as we will see in the anatomy of extraocular muscles. So what is the difference between the collagen fibrils of the sclera and that of the cornea? The major difference is that the corneal collagen or the scleral collagen fibrils are variable in diameter, have irregular arrangement with high water content and no blood vessels, and this is what makes the sclera looks white. So the sclera looks white due to high water content. It has a variable diameter, and irregular arrangement. That's why the sclera is opaque. The sclera is not clear, with no blood vessels, and with cells are fibroblasts and some pigment cells. Then finally, just the most posterior layer of the sclera, just adherent to the uveal tissue, it's called the lamina fosca. Lamina fosca, meaning that there is elastic tissue and collagen tissue, and this is the most inner layer of the sclera, which looks brown in color due to presence of melanocytes. The knowledge of anatomy of the sclera will be of particular importance in case of strabismus surgery. So if we need to hook a muscle of the strabismus, then we need to know what are the layers in front and what are the layers behind. So if we wanted to hook a muscle in strabismus surgery, we first open the conjunctiva, then we open the tenon capsule, and we will be able to identify the muscle, and the muscle will be enclosed within the posterior tenon capsule, and finally the posterior tenon capsule will be resting into the episclera, and finally the sclera. So again, from anterior to posterior, there will be conjunctiva, and anterior tenon, posterior tenon, episclera, and sclera, which will be separated from the choroid and the ciliary body by the lamina fusca. Blood supply of the sclera is minimal. As we said, the episclera is the most vascular layer of the sclera, and it is usually coming from the episcleral blood vessels from outside and from the choroidal blood vessels from inside. So here we see that anterior to the insertion of the recti, the sclera is supplied by branches from the anterior ciliary arteries, while posterior to the insertion of recti, the sclera is supplied by the long ciliary artery and the short ciliary arteries. So the short ciliary arteries just will supply the posterior sclera, while the long ciliary arteries will supply the most of the sclera till the insertion, till the level of insertion of recti, and anterior to the insertion of recti, it will be supplied by the anterior ciliary arteries. Nerve supply of the sclera, it comes from the long ciliary nerves. So as we said, the two long ciliary nerves will perforate the sclera from behind to reach the anterior part of the sclera, supplying it like the cornea, while the posterior sclera will be supplied mainly by the short ciliary nerves. So as a general rule, we have the anterior sclera supplied by the long ciliary nerves and arteries, and the posterior sclera supplied by the short ciliary nerves and arteries.